So although I am I'm not that good looking as Dmitry Karmpaliotis. I am Khaldoon Alaswad. I'm filling for Dimitri. Where's Dimitri's picture? So I just got here. So, we have a great session today. Dmitry Feldman.
He's not coming, yeah. So both Dimitri had issues. So.
Okay, both Dimitris are not here, so we are filling for them. And we have Salman, Arain, Rajiv, Gulati, Judit, Karacsonyi, and Manoj, Kesarwani, Timothy, Mixon, and Thufam. So the first talk, this is a complication, extracardiac complications. I'm looking forward to it. I'm not sure why I have to moderate this session because I cause a lot of complication, but access site complication going to be by Konstantinos. I can't read it.
Marmagkiolis.
Marmagkiolis. Okay. So when you give your talk, you are standing there. You're going to face the audience. So if you need to read something from the screen, you are welcome to do, but you have in front of you.
Perfect.
All right?
Hello, everyone. Thank you for this. Nice to meet all of you. Thank you for the kind invitation, Mano, this great conference. So I was asked to present a complication. I was trying to find something a little bit different than, you know, all the growing typical complications. So I'm presenting one of our big complications of last year. So it's an axillary artery complication. I'm Konstantinos Marmagkiolis from Tampa General. Nothing to disclose. So this is a patient who was referred to us by the VA, typical VA patient, 79-year-old referred from the VA for cabbage. Typical patient. There's supposed to be a different updated presentation. I'm not sure. I don't think. But anyway, I can give you verbal. There's supposed to be another update. So 79-year-old typical VA patient, recent non-STEMI. Typical VA patient, hypertension, cholesterol, diabetic, COPD, smoker. He had left below the knee amputation and peripheral disease on the right side. And this is the films from the VA. So left main 3-vessel disease, heavily calcified. His ejection fraction was around 40%. He came to the VA with chest pain. The VA doctors did the diagnostic cath. Targets, they looked good to them, but our surgeons reviewed it and they turned him down. Now, the next picture, you see the peripheral. There was a right common iliac stenosis, but there was diffuse disease below the groin. He had SFA, severe stenosis, and run of disease. And the left was occluded with left below the knee amputation. So he was evaluated by cardiovascular surgery. They thought the targets were small, although I think they looked pretty good. And he was sent to our heart team, and we decided to do multi-vessel PCI with left axillary impella placement. I don't know how many of you are using axillary impella. So this is the angiogram of the left subclavian axillary. Brachial, it seemed to be having some mild disease, nothing crazy. So the way we do the axis, we get left radial axis. We always leave a sheath for monitoring of the blood pressure, but we also advance a wire that guides us with fluoroscopy to get access. So we'd use ultrasound, but we also use the wire with fluoroscopy to get access. Access without complication, we put the two percloses, and then we advanced the impella from the left axillary without any problem. It was advanced without any problem. And then the PCI, the right coronary was relatively easy. We did balloon stent. Good result of the right, it was pretty fast PCI. The left was a 2.5-hour case. So we tried to open, we fixed the left main, the LAD, we tried to open the CTO of the circumflex unsuccessfully. So finally we decided to put stent the left main to the LAD. And that was pretty good result, but we lost the left circumflex. So after the end of the case, patients start having severe arm pain. We put the percloses, everything looked good, but the patients start complaining of severe left arm pain. So we checked the pressure in the radial sheath, and it was systolic pressure of 30. So we realized that pretty much the axillary had closed. So we went from the groin, from the right leg where there was a stenosis, we put the catheter up, and we did an angiogram. And you can see that there is a dissection where we got the access extending all the way to the brachial. So the clinical challenge now is, what do you do? The first thought was to start giving vasodilators, either from antegrade.
So maybe we can stop here for a second, right? Have the panel discuss a little bit and see. And whether, if you have any questions, have a microphone here, raise up your hand, and we'll bring the microphone to you.
So I just want to ask, I want to ask the audience and the panelists so how many of you would have placed an Impella in this patient? And how many would basically got away with would think we can get away without placing an Impella, and what strategy? Me too. Okay. So now we faced with this axillary dissection. Rajiv, we start from you. What you kind of 3 sentences management, and we're going to go down.
Yeah. First, I'll be very happy that you have distal and proximal access. You still have the distal, so you've got true luminal control at both ends. I think you know you're going to win at the end of the day with that. So that was a great planning strategy. Yeah. You can't leave the patient alone with a malperfused upper extremity. So I think you're conservative alone. I'd be very reluctant to do that. My view, I think if you can get flow back down, and that should be your therapeutic endpoint, adequate flow with no pressure gradient, with a balloon angioplasty strategy at the tightest point, and then leave it alone would be my kind of first strategy. But it's great preparation you had for this case. I think that's the key learning point for me.
Dr. Pham?
I think you did your due diligence by taking an angiogram of the upper extremity artery to make sure that you could have the Impella placed there. I want to throw a little wrench in the scenario. Would you have considered doing a femoral Impella CP and intervening on the iliac artery prior to, and then performing your Impella CP or PCI there, and not even address the axillary?
Well, in retrospect, probably yes. It would be an easy lesion to fix. The problem was that the runoff was very rough. So the team thought that maybe it would be better. Obviously, it was not the safest decision, but the team thought it would be better to go from axillary.
So what was the ACT throughout the procedure? Do you remember?
We always we try to keep over 300. It was CTO, so it was 300 throughout the case.
To answer the question, how would we deal with it? I think it would be endovascular. It is great that you've got access on both points. Sometimes we'll even have a wire across when we're doing the final setting of the sutures, from the radial or from somewhere else, so that in case we completely occlude the vessel, you'll see that occasionally. And the other question I had was, do you routinely take a sheath shot after you place the axillary sheath to see that you actually hit the right spot?
Well, typically we put the percloses, and then we remove the Impella, and then close the percloses. So
no, at the beginning.
I see. With the micropuncture, no, we didn't. Like the same way we do in the groin. No, we didn't.
Yeah.
So Salman, I want you to address the question, and address
Oh my God.
how is it important to take a shot when you use large bore access? How important it is?
Yes.
Okay.
Right. No, okay. So I mean, great points have been made. I mean, I only have limited time, so 3 comments. I think sheath shot is important because it helps you understand the position of the sheath. Oftentimes, accessing from the left going to the ascending aorta can introduce a kink, and that kink can traumatize the artery in addition to whatever suture device you may use. The other thing is it gives you an idea of what kind of ischemia you're actually causing and how much time you have, and that's my second comment. With the patient with this much disease up front, I would have just done the right and the left main to LED. He's been living without that circ for a long period of time. You can always bring him back and do that. And the third point was exactly the one that you made, that you've got to have a wire in there. We don't walk away from large bore access without taking an angiogram, and that's one of my sort of hesitations when we have single access. Sometimes if there's a lot of disease, you always wonder what's going on. So sometimes I might just take a 4 French from the other side.
Do you take the angiogram while obtaining the access with the micropuncture sheath?
Yes.
before?
So I do that though. I haven't done axillary in a few years. I don't know if I did that. With axillary, usually I have a wire. So I do it slightly differently. I park my J exactly where I want to get access, and I stick the J with the micropuncture. So typically, I don't take a picture through the micropuncture, but once I put my first 6 French sheath in, prior to doing the PER closes, I will do access just to make sure there's no puckering of the artery or dissection or something like that.
Audience, any questions? So, Judith.
So I perfectly agree with the opinions before me. One comment is that I would probably chose rather the femoral and link balloon dead lesion and go with the femoral if we would have picked that there is a need for the impella, although I also think that maybe
why are you
it
saying
wasn't.
that?
Because I think with the axillary it could be more complications dealing with, and when we get these large bore accesses, first we usually go with micropuncture, then do a 5 French sheath, take an angio, and then upsize, and then make sure that there's not much complications. Yeah.
I don't have too much more to add other than the fact that I feel whenever I consider the Impella device that there's a certain price that you pay, and you have to really be sure that that price is worth it in certain situations. I feel so sometimes with multivessel disease, with good management, with maybe 2 interventional cardiologists, that you might be able to get through the periods of time of ischemia and perhaps even shock.
Anybody has any questions so far? Yes.
Abdul from Norton Healthcare in Louisville. So we do a fair amount of axillary access for impellers, and just a couple of points is we typically put it like a 4 French up from the radial and take a picture, obviously put a wire up into the arch and stick the wire outside the rib cage. That's our typical approach. But what I wanted to bring up was when we put the impeller sheath in, we take a picture to determine what the distal flow is to the radial artery. That, your point, tells us how much ischemic time we have, because for the leg, you can leave it for hours. For the arm, you barely have 2 hours before it goes ischemic. The only other thing we do is if we think the impeller sheath is actually obstructing flow, we do a femoral to radial temporary bypass, external bypass to it.
Great comment.
Yeah,
How about let's continue because we finished the discussion panel.
So the discussion was if we would go from antegrade, retrograde vasodilators, if we fix endovascular, or if you call surgery. So the decision of the team was to call surgery. So we got our endovascular. So the vascular surgeon came and decided to fix this with endovascular approach. Actually, the plan from our intervention cardiology was to go from the radial, since it was felt that it was a dissection starting from the axillary down to the brachial. However, the vascular surgeon scrubbed in with us, and he decided to go from the groin. So he went from the groin and wired the brachial, and this is what happened. So this is the first picture. So we had the pressure. So the pressure was in the 30s. Patient was in severe pain. We gave morphine. So just after the first stent, the pressure improved a lot. It went all the way to the 70s. Still, there was still a gradient over 50 from the systemic pressure. And as you can see, there was a dissection. So then he put the second stent, PTX. The pressure went over 100, and the pain improved a lot, but there was still some residual dissection. And then he put a third stent. And this is the final picture that you can see that there is still a spiral dissection extending all the way down. But at that time, the pressure was, the gradient was only 20 millimeters of mercury from the systemic, and he decided to stop. So we left with the 3 stents. Gradient was around 20 millimeters of mercury. Patient was placed on DAPT, and we left there. So the
was prolonged balloon inflations, was that attempted first and it was just inadequate, or did y'all pretty quickly go to stenting?
He went right away on stenting. He did not do prolonged inflation before he put the stents. So he immediately put the first stent. His idea was to close the entry dissection first and see how the gradient would be.
And did you externalize the femoral wire out the radial to be sure you were in the right plane? Because there is that risk, right, with you end up stenting the false lumen. I mean,
In the false lumen, yes. No, he did not. Actually, he did not use our radial axis at all. He used it as a pressure, but he did not put a wire through there. Our idea was that since the dissection started up, and obviously it stopped somewhere, it would make more sense to go from the radial up and advance the stents there. And there was always the question, after we saw the first and the last picture, there was always a question of maybe the wire at some point was in the section plane and re-entered.
Because for the interest of time, we have to move. Thank you so much for presenting this case. We learned a lot from. Okay, the next speaker going to talk about systemic embolization, and then Prasad, please come to the, not podium, the floor.
All right, thank you. So, yeah, I was asked to present a case of systemic embolization in the context of a coronary intervention. So let's see, okay. So first, I want to thank my partners who are not here for having these interesting complications. That way I can show them off at conferences. So this is a recent case that we'll show. So when you think of systemic embolization during coronary interventions, you're basically thinking, okay, something went to the brain, right? That's one option. Or something went down to the extremities. And they could be access site related, embolization to the extremities. And so the case here is a 79-year-old male. He comes in with severe substernal chest pain, inferior posterior MI. In this case, it was a dominant circumflex, gets a PCI to the circumflex, so no big deal. This was from the right radial approach. But there's some concern for some osteal left main disease. It's IVUS, and the plan is either staged PCI there versus CABG. There's a heart team discussion ongoing. It's important to note that when he presented with his MI, he was hypotensive, needed pressors, EDP was up a little bit, so they decided to place a balloon pump in the left common femoral artery. On ultrasound, the bifurcation was really high on the right. And this is the best image I could find of the groin shot on the left. And I guess my one point here that I want to make is it's really important to do a good femoral axis angiogram. I use DSA for mine. I don't spare contrast on this one injection. You get a good view. You really want to know what the anatomy is like and if there's any issues. So, the typical sort of shocky patient, lactate a little bit up, trope was high. He gets all these things weaned off. He's in the ICU. His EF while he was on support with the balloon pump was 50%. Once they wean everything off, his EF is down to 26%. And you don't see the LV clearly there, but there's no thrombus with DEFINITY imaging. 4 days after he presented, the balloon pump's removed. The fellow pulls it, holds manual pressure, and he seems to be recovering. Now, 3 days from then, after the balloon pump's out, he starts getting acute left foot numbness and has a posterior tibial pulse, but no dorsalis pedis. And then his leg symptoms worsen, they put him on heparin. So I guess what's the differential diagnosis? What are we thinking in this case? And I can pause there for a second.
All right, we'll start with Judith. What do you think the differential diagnosis?
Obviously, I think exercise complications.
It's 3 days later. Just remember that.
I know, but that could be late complications. Another thing is that I guess I don't know if the patient was on prophylactic anticoagulation before, like on enoxaparin.
He was on heparin during the balloon pump phase.
During the balloon pump days, heparin, and then. Okay, go ahead.
So, Salman.
How long was the balloon pump in, sorry?
It was like 4 days of the balloon pump. Now, he was ambulating after it was removed, and this is 3 days later.
So 3 days after the balloon
3
pump
days,
came
he's
out.
on the floor now. They're talking about discharge, and now his leg is down.
And the other question is, what was his anticoagulation once the balloon pump came out? Was it
just DAP,
Just DAP,
Brilinta and
I mean, to me, it suggests, it's acute stuff like dissections happen acutely. Chronic stuff like this, more often than not, is thrombus that's hanging or somewhere, some shaggy aorta. Something got dislodged, it seems. The question is, where was it? Something in the iliacs or somewhere higher up? Or it could even be AFib. I mean, who knows? But that's what I would think, a large embolus. And I would perhaps want to do an angiogram.
Question from the audience?
Yeah, the timeline 3 days is a little bit out. It may be access site complication, but you did mention his EF dropped from 50 to 25%. Did he develop LV thrombus in that time period?
So they repeated an echo, again with Definity, no thrombus, but they saw the EF was much lower.
So go ahead. The atherothrombotic, embolization, cardioembolic. So these all the differential diagnosis.
So, you know, there's always a question of what to do next. And, you know, in this case, they moved to invasive angiography, which, you know, personally I think is the right answer to really see what's going on. So here's the angiogram. You can see ectatic distal aorta, you know, kind of diffuse calcific disease of the iliac system. And then if you look at the SFA on that left side, the flow is a little bit slow. And look at the bottom of the screen, and I'll show it here as well. There's a organized filling defect sitting right there. So, you know, does this lend some information one way or the other?
So, I mean, it could be a cast of an artery from up top, but you know, the whole idea is that sometimes these things form up top. If you ever do a sheath angiogram after you've taken a balloon pump out, even an impella that's been for a few days, oftentimes you see something hanging in the common femoral, just sort of waving in the wind. So it could be just an extension of that.
And could be foreign material from the balloon pump if it is disrupted or something like that, right?
Okay, so they did the full runoff, and you can see on the still image the stasis of contrast right by the P3 segment of the popliteal and the tibials. And you can see that the tibioperineal trunk's out, it's kind of just AT runoff there. And nothing much going to the foot, kind of faint perineal and PT runoff. So they were then deciding what to do. You know, do we do an embolectomy, thrombectomy, lytics, anticoagulation?
How did they close the site again, sorry?
The balloon pump site's manual pressure.
Yeah.
It was a pull and hold.
So an angioceal or something crazy like that.
No.
So can I ask, is it okay, we're going to have some discussion. Salman, how would you approach this complication?
I would do endovascular. I mean, I think at least you'd go down and sort of try to figure out what's going on in that SFA to get that out or open it up. You would presume whatever is below that is just more embolization from that, but that seems to be sort of the current nidus of what's going on.
Dr. Pham?
Yeah, I would agree. Endovascular approach, I would go right common femoral artery, probably use a 7 French penumbra system and intravascular image after that to confirm that thrombus is my mechanism of injury here.
I want to ask the expert in peripheral. I don't claim I'm one. I don't know, Rajiv, you don't claim that. But the question I have, would you get access from the pedal to fix that complication?
Before, it's a great question. I wouldn't dismiss the idea of surgical embolectomy here. I mean, this is what they've done for forever. They get it all out. They don't distal embolize. And I think I would absolutely have a very close conversation with the surgeon. But I think your pedal access question is a great one.
So that's always a good question. I think you'd asked that before. I think thrombus burden is high. It's very hard to get that thrombus out from the popliteal without disrupting. So unless it's something solid, we can't extract it. We do have NRE now. I mean, that would potentially be an option, but it's nothing large bore, because if it truly is organized like that, you have to break it up, and when you do angioplasty, it embolizes more. So to your point, I may get pedal access just to protect it and push it up maybe. Mm-hmm. Having said that, I think surgical embolectomy is probably the answer. And actually, a comment I wanted to make on the last case, and perhaps this one, IVUS, man. I'm a big believer in IVUS when you don't know what's going on with the angiogram. So again, the dissection that they try to treat, if they'd known what the extent was, same thing here, what are we actually dealing with?
All right. Anand.
Okay, so the approach was endovascular, and so the sheath was upsized on the contralateral size, and the penumbra lightening was used with multiple passes in the SFA, popliteal, tibioperineal trunk. And they even did some adjuvant balloon angioplasty of the AT, which had some filling defects. And they were able to basically restore flow down with just thrombectomy without adjuvant lysis catheter or anything like that. They didn't have a nice little picture of what came out, which I wish they did, so we could see what it looked like. But nonetheless, they picked that. So nothing too crazy. So there was probably, in my opinion, some thrombus in the left iliofemoral system. It was sitting there and embolized. 2 DEFINITY LV studies didn't show thrombus, so it's unlikely. I think invasive angiography is the way to go. Even if you're planning on calling a surgeon, call them after you've done an angiogram. Don't call them before that. Aspiration thrombectomy, if there's multi-level embolization, you can leave a lytic catheter down overnight. So that's what I have.
Thank you so much. This is great.
It's also not an uncommon presentation for an abdominal aneurysm, and he did seem to have an abdominal aneurysm on.
So those who are facile with peripheral, do you start with a thrombectomy or you start with thrombolysis or both?
I think it depends on the time course. So if you're working, sometimes you start doing a CTO or you're doing some kind of instant restenosis. And what you realize is that the instant neointima was a small segment and the rest of the SFA was clot. And as you improve flow up top, the clot just displaces downward. That's when you want to try and do something like lysis perhaps. But something like this, which you feel is a little bit more organized, you may want to go with embolectomy. So I think it depends on the time course and what you feel is the consistency of the material that you're trying to remove.
Do we have any vascular surgeons in the audience? All right, if we have a vascular surgeon, it would have been very lonely. Thank you, Anand. Appreciate it. Okay, so the next speaker, thank you for saving us 2 minutes too. Amit Amin, he's going to talk about contrast-related adverse event in a case presentation.
So actually, Manoj Kesarwani is going to do the talk. Amit had some issues with travel, so
okay.
Thanks so much, Manoj.
Manoj, you are going to give the talk.
It's a real pleasure to be here today. I was going to present a case related to adverse events associated with contrast media.
So don't see those slides.
Okay. I have no disclosures related to this presentation, and so obviously with contrast media there are a whole host of adverse effects that can take place. I was going to focus on contrast-induced acute kidney injury. Of course, anaphylactic hypersensitivity reactions are something we need to be aware of. Also, contrast media obviously has an effect in terms of hematology, including thrombosis risk, but we'll focus on nephrotoxicity. Listed here on the slide is the mechanism of action related to injury to the kidney, where I think we would all agree that hydration is a really key part to treatment. So this is a case I dealt with about a year ago where an 84-year-old gentleman presented to our emergency department at UC Davis with a worsening exertional angina and was admitted to the cardiology service. Cardiac troponins, high sensitive versions, were stable, and the 12-lead ECG is shown, largely unremarkable as well. And the patient's past medical history is significant for hypertension, as well as heart failure with preserved ejection fraction, and then stage 3B chronic kidney disease. He's on common medications of aspirin, rosuvastatin, and furosemide, has a remote history of tobacco, and is a primary caretaker for his wife, which will become relevant shortly. And so this is his myocardial perfusion imaging about 2 months ago, where he has clear scintigraphic evidence of myocardial ischemia involving the entire anterior wall, appearing worse in the apical to mid segments. And then obviously he ended up going to the cath lab where there was concern about his creatinine. As mentioned, his creatinine was 1.7 milligrams per deciliter and his EGFR was on the low side. So we did biplane imaging here. And this is a shot of the right coronary artery where you see that it's mostly ectatic with mild to moderate disease. And then moving on to the left coronary circulation, what you'll notice here is a high-grade lesion extending from the distal left main into the LAD, and I think it's less obvious perhaps in the iliocardial view, but more obvious perhaps in the iliocranial view that there's even high-grade disease involving the proximal circumflex. And so, given this situation, this presentation, we used a heart team approach, deciding whether the patient would be a good candidate for CABG surgery or whether we should consider multi-vessel PCI. Part of the concerns here were that the patient was really pushing for the idea of multi-vessel PCI being the primary caretaker for his wife. The recovery involved with CABG surgery was of concern. I think one thing that comes to mind here is how CABG surgery being on pump would affect his ultimate recovery related to his kidney if there's further injury versus contrast associated with PCI. And then other factors here that are relevant is a patient has normal left ventricular function and his LVDP on that coronary angiogram done with biplane imaging where we received about 30 cc's of contrast was 14. And there's incidental note of infrarenal abdominal aortic dissection, 1.6 centimeters. Not sure how that developed because all the procedures we did were radial. And just to remind you, so patients should always be assessed for risk of contrast-induced acute kidney injury before PCI. And so I'll stop here and ask the panel how they might consider a situation like this to help determine which patients where we need to be really careful with in terms of contrast.
Rajiv?
Yeah, I think you're asking the wrong person here because I have a kind of a controversial opinion that contrast does not cause nephropathy. We all live procedures causing nephropathy all the time. We have absolutely zero evidence it's a contrast. So that's why the term now has changed. It's now contrast-associated nephropathy and not contrast-induced. So my counterpoint, and I'm not addressing your question, I'm sorry, is that there is a risk of us being nihilistic and not getting the patients a CT scan with contrast that they need, not giving enough contrast at the time of the angiogram and saying we can do zero contrast and IVUS and compromising patient outcomes by just believing that the contrast causes nephropathy. So that's my counterpoint. My related point is that if it isn't contrast, what is it? What is procedural aspects after embolization? So all of the other good stuff that we do, single guide, careful not to scrape the aorta, radial access that we know has a lower rate of AKI compared with femoral for matrix. I think they're all of the things that we should focus on, so the hydration, and maybe downgrade some of the concerns about these contrast volumes that we have.
To prove your point, in Henry Ford Hospital, we have the least amount of contrast compared. We have the Blue Cross Blue Shield. So the Blue Cross Blue Shield tells us the data of 31 hospitals in Michigan. We have the least amount of contrast used. We are in the lower, like 10 percentile of amount of contrast, but we have the second worst CIN. And because the patient who actually came to us from the rest of the 31 hospitals, very, very sick.
I mean, that's absolutely fantastic. I'll just give you just one other piece of data, a fantastic, huge observational study, contrast CT. They matched controls, patients with the same level of sickness, same diseases. This is like hundreds of thousands of patients came to hospital without contrast CT, exactly the same creatinine curves. So it's the sickness of the patient, the hypertension, the drugs that we give them that cause the nephropathy, not the CT contrast.
Dr. Pham, that's a very, very interesting discussion.
Yes, I actually tend to agree with what has been said already, and completely anecdotally, some nephrologists I used to work with said, do what you need to do. The contrast isn't going to hurt the kidney. So if we get that kind of endorsement from nephrology, I think that's a good thing. Doesn't mean we still shouldn't be judicious in the amount of contrast that we use and the timing. So if what you highlighted, multidisciplinary heart team approach, get the patient's input, and if they really choose the PCI route, make sure we're using, if it's available at your facility, dynamic coronary roadmap to minimize our contrast injection, stage the multiple PCIs if we can, depending on the patient's ability to come back for more than one procedure.
All right, Tim?
Count me among the skeptics that contrast does not cause nephropathy.
Why do you say that?
Because we just have too much data showing that it does occur after contrast-related procedures. Now, no doubt, you know, a sicker patient is going to be more prone to it. So the sickness and the level of morbidity is an important part of it, but there just seems to be too much association with the occurrence of it after contrast procedures. But I also want to say one other possibility, because you mentioned surgery, and obviously if you go on pump, that can be very insulting to the kidney. But you could consider off-pump bypass here, particularly if I didn't really see a lot of disease that would be treated other than the LAD, so it could be a single vessel bypass off-pump.
I want to stick to the contrast thing. Because this is near and dear to my heart. So they say, like, if you do a venous dose of contrast, very unlikely to be associated with renal failure, versus arterial dose, which is a proof Rajiv's and Dr. Pham's.
And let me extend that. A single 5 cc injection into a renal artery should give you 500,000 times the risk of contrast nephropathy, given the dose issue that you're injecting, compared with a coronary angiogram, such diluted stuff that goes around. Yeah. It doesn't make sense. It's not the contrast, it's the procedure.
Okay, so we're gonna see what Salman gonna have to come up with.
No, I don't. So I just put on my tab the contrast bottles, you know. No, but seriously though, I think those are good points. So the point here is that these are high-risk patients, and you know, sometimes we do 89-year-old patients, you give them like 300 cc's, their creatinine doesn't budge. And sometimes you do relatively healthy patients, but they're the diabetic who's not been diagnosed, and all of a sudden you don't realize the aortic arch is all like, you know, shaggy, or you've got atherosclerosis. So the bottom line is, I think optimizing the patient in other ways perhaps is better. So sometimes don't rush in to do your PCI when they're in heart failure, perhaps optimize them, stage procedures if possible. So I think that would be one option here also. But I think most of us, you do this long enough, you realize that contrast is not as bad as you think it to be.
Okay, Judith, you have the final word on contrast.
So I agree with the previous comments that it could be also the comorbidities of the patients and the age of the patients, diabetes, and all these other cofactors which contribute to kidney failure. But I think we should still limit the amount of contrast. So we could do, at Columbia, we do this protocol, which is similar to the Poseidon trial. So we, in these cases, we get the EDP first, and then we optimize the hydration of the patient based on that and based on the ejection fraction. And the patients get hydration before the procedure, during, and after the procedure as well. And also, when we try to limit the test injections. So before engagement, we use saline injections to find where if we are doing a diagnostic angio. So we try to limit the contrast with that. Also, the excessive use of intravascular imaging is very helpful, I think, in these cases, to not to continuously check your vessel after each balloon inflation, but do imaging rather and optimize the stents and the outcomes with that.
Very good political answer. You satisfied everybody. It definitely, like, patients who require higher contrast, they are sicker and the procedures are more complex. So probably the truth lies right in between. Go ahead. What did you guys do?
Okay, well, I don't want to bore you with data, but you talked about the Poseidon trial, or at least referenced it in terms of LVDP-based hydration. I think that's a really important part here. This is just a curve showing that when we do use an LVDP-guided hydration strategy, that we can reduce the incidence of acute kidney injury due to contrast-induced nephropathy or contrast-associated nephropathy, contrast-associated nephropathy. And this is a remedial 3 trial comparing ultrafiltration guided therapy with the renal guard system versus EDP guided group, where you can have additional benefit as well with a low number needed to treat. And then going back to the Poseidon trial, it's clear that if you give patients more fluid, that's driving the outcome where the number needed to treat is relatively low. And then if you look at outcomes at 6 months, that it is decreasing the incidence of major adverse cardiovascular events when we look at a composite of all-cause mortality, MI, dialysis at 6 months, which is, I think, meaningful. But I think Dr. Gulati references a really important idea that, yeah, maybe it's not just the renal function alone, it's the comorbidities. And so I'm sure all of you are aware of Dr. Ali's group and the push for this concept of ultra-low contrast imaging and PCI. I really like this algorithm because of the fact that it really is about optimizing PCI outcomes. The things that we do already, such as coronary physiology, intravascular imaging, form of IVUS, are really beneficial. So I would just point out that identifying the high-risk patients is really key. Thinking about biplane imaging in addition to maybe not taking all the images that you normally would take, but you still need to make sure we get the data that we need. I think this concept of staged PCI that the panel had mentioned is really important as well, spacing out procedures as much as possible when you can. Also, this concept of the dynamic coronary roadmap available by Philips and sure other companies as well. and the idea of intercoronary imaging physiology so that you're intervening on a lesion that really needs to be intervened on and not exposing a patient to unnecessary risk with contrast. And then here in this case, we end up using mechanical circulatory support because of the fact that, I think this references what Dr. Gulati's mentioned, that the hypoperfusion maybe during your PCI may be of harm and maybe not the contrast either. And so we ended up using a DK crush technique here. And we ended up treating the LED in diagonal as well. This is just listing out the diagram we followed where we did use IVUS imaging. And then this is a summary here, and this is how things look. But this is a discussion or lecture on complications, and here I used a lot of contrast for what ended up being a very complicated procedure. The maximal law contrast dose here was around 250 cc's. I was very fortunate that his creatinine actually was a little bit lower 48 hours later, but I'll admit to you that he did come back a month later and acutely decompensated heart failure with even higher creatinine. And so the key learning points, I think, are to think about the heart team approach always, and perhaps we should include a nephrologist in that. There is good evidence now for the idea of LVEDP-based fluid hydration to not only prevent contrast-induced or contrast-associated acute kidney injury, but prevent major adverse cardiovascular events. And there's certainly increasing body of evidence to support this idea of ultra-low contrast angiography and zero minimal contrast PCI, which are rooted, I think, in optimizing PCI outcomes already with IVUS, and even using dextrans-based SUT as shown in these images here, or even in Impella on the renal guard system. Thank you.
Thank you so much. Really amazing. So there is a discussion here. I wanna open up. So interestingly, you used mechanical circulatory support, and a danger trial showed us that actually patient who received Impella had more actually CI and kidney failure. This is not a shock patient. So Rajiv, what's your thought on this? Like, would you first of all use Impella for this, and do you think really that protects the kidney?
Oh, it's a great question. I bet there's be like a range of opinions in the audience. It just shows that we actually don't know the answer here. Personally, we would not have used Impella for this case. It would have been just a PCI case, and I don't know about the kidneys. It's a really good question, but your danger point is true. There was higher rates of kidney injury after Impella, but the question is, was it the Impella, or was it the adjunctive co-treatment biases, that, more diuretics, more aggressive measures that may also partly explain the better outcomes?
Dr. Pham?
No answer, sorry.
No answer, obviously. Pham, I hope you give us an answer, Dr. Pham.
I probably will not, but we probably would not have used an Impella on this case, and much to it, I think we don't really appreciate how traumatic an Impella is. We think it goes in, it's supportive hemodynamically, but there's hemolysis that can happen if the Impella is not positioned correctly. And I think it's a stress and trauma to the coagulation cascade that we don't truly understand all of its aspect.
Yeah, because the data about renal protection with Impella is actually registry data and a retrospective. So like this shouldn't be as good as the danger data, which are randomized, and both patients received the exact same therapy except one used Impella, one didn't. What do you think, Tim?
It's certainly debatable to use it or not. I could see us going both ways. At my center, we do use it for high-risk PCI, but to the point that we've talked about earlier, yes, Impella could induce problems that could lead to worse renal function, but if you have inadequate cardiac output, that's also something that leads to worsen renal function. Interestingly, just to throw a tidbit out from the TAVR world, what we see, if I do a PCI, especially a complex PCI like this, very common to see creatinine higher the next day, whether they go into a full-blown AKI or not. After TAVR, almost every case we see the creatinine less the next day. And the only explanation is that they have so much better cardiac output that that's probably a good thing. So I think, to your point, you were thinking, I want to maintain cardiac output throughout the procedure consistently as kind of a renal protective strategy.
Okay. So to the Impella question, it's on a case-by-case basis. I probably would have done this without Impella. But just to make a point, so I think the reason this low contrast philosophy is good in this contemporary era is I think it makes you a more mindful operator, right? So you're thinking about these things, and that's the real value in this. You're optimizing hemodynamics, you're making sure that you're not rushing
It's
into
not the
things.
contrast.
Yeah, huh?
It's not the lack of contrast.
It's not the lack of contrast. It's the mindful operator, which I'm a big believer in. And then the other reason to do this is a lot of people, they don't know this, so this is a great marketing tool. So in my hospital, I'm known as the low contrast, zero contrast guy. So I often will get cases which I feel other people can do, but they say, hey, you're used to doing this. So I think do promote it with some people because it'll give you business.
Okay, Judith, I'm sorry, we're gonna have to move to the next speaker. Jeffrey Schussler gonna present a case, complication of hemodynamic support, which is really kind of very timely, this discussion. We saw one complication, the first case, and this is probably, I'm not sure if it's a complication of it or not, but, and now you're gonna enlighten us.
Probably not. Thank you for this opportunity. Dr. Balakis, Manoj called me up and said, Jeff, I know you have complications. Can you show us one? So I have no disclosures. So I was in the cath lab one afternoon and we got a call from the ER, as we often do. Hey, we have this patient. He's a 73-year-old man. We don't know anything about him, but he collapsed at work. No prior history. They did CPR. The AED shocked him. He was in AFib when the EMS arrived, and now he's in our ER, and do you want to take him to the cath lab? As we all often get this question. Do I want to take him to the cath lab? I don't know what's going on with him right now. He's talking to us. He's not having any chest pain. Here's his EKG. So creatinine was a little bit high, burdened to the last case. His potassium, interestingly, was over 7. His lactate was up, and his pH was low. And I looked at the EKG, and I'm like, well, I'm not sure that this is a STEMI. Let me come down and take a look at him. And I'll pause here and just ask, post-arrest patients, they don't all fit the same criteria. I don't know if the panel would automatically take this guy, take everybody to the cath lab post-arrest, would they take a look at him? What are your thoughts?
I'm going to start from Judith here.
I think it could be from the hyperkalemia and probably...
Take him to the cath lab
immediately? I would correct first the hyperkalemia.
Okay.
And then, and also with the EMS presentation, the AFib could have been a Torsad, I think, which we didn't recognize.
I'm super glad that you said that.
Yeah, I think I would agree that I would want to correct that as soon as possible and perhaps then move to the cath lab once I saw it corrected.
Do you need more answers?
No, I think that's great. So I don't know what's going on. It's not a clear STEMI by EKG or presentation or anything like that. So I thought I'd walk down with my fellow. We'll go take a look. By the time we got there, they said, well, he was acting a little funny, so we sent him to the CT scanner because everybody needs a CT scan. So they were going to scan his head, but while he was in the CT scanner, he once again had VF. Presumably he had something like that out in the field. He was intubated, he had persistent VF, and then they called the ECMO team because they couldn't get him out of VF. I put up here the hard stops. He did not meet any of our hard stop criteria. They don't put everybody on ECMO just because. But now he's on ECMO. And just to give you guys a picture of what happens, if you haven't been part or you're not part of the ECMO team, it's a bit of a circus. So they do this predominantly in our trauma bay. And there's usually somewhere between 10 and 20 people in the trauma bay. Large bore catheters, venous and arterial access. And they don't do it with any kind of fluoroscopy. So this is a blind stick with, truly good operators. It's part of the trauma team or the surgical team that does it predominantly. So he is now on ECMO. He is continuing to get CPR.
So, question.
Yes, sir.
I do ECMO in the cath lab. So, and I've seen ECMO put in the bedside. I did one in bedside, but we knew the anatomy. So what kind of venous cannula do they use? Echo TEE to guide the venous cannula? How do they make sure that the venous cannula is in a place?
So they have a sonocyte bedside.
Sonocyte.
So they get venous return and they've got sonocyte access. That's what they use.
Okay.
Yeah, I think the issue with bedside is sometimes you can have liver laceration, especially if you're using the Amplatz wire. I was just going to say that is suspiciously clean field there for ECMO.
These are actors.
Yeah, that looks like staged to me.
This may or may not have been before. This is before they actually got access, but this is what you see from above. It's very interesting. They video all of these so that they can do the analysis afterwards on was everybody in the right place, did they do their job, so they learn a lot from that. But it's a very good question, you know. They don't have fluoroscopy, they're doing it somewhat blind, they have limited knowledge of where they are. So after all of this, he VF'd again. I said, you know, it's probably not a bad idea to take him to the cath lab. So here we are. And this is probably, you know, at first I was like, I don't know if it's a cardiac issue. I also thought, well, maybe we should just treat his potassium. But it does kind of look more like it's a cardiac issue. So we've got left main damping. There's 100% right coronary that's occluded with collaterals from the left. So basically all of his eggs are in one basket. Left main PCI was performed, and this part honestly went fairly well. You know, he's on ECMO, he's very stable from a hemodynamic standpoint. Doing left main PCI with someone on ECMO is actually not that bad. So as opposed to putting in your own support, if the support is there, everything's controlled. So there is
especially osteal, right?
Right. So this went pretty well. It was a JL guide. We got a good result. It was about a 5mm diameter stent. And then afterwards, he didn't have any more VF. And interestingly, I don't put people on ECMO. And what they do after someone comes in with one of these post-arrest patients and they get ECMO is they basically treat them like a trauma patient, and they do a head-to-toe CT, pretty much. And so you can see multiple sites of active bleeding. This is a complication discussion. And I went through this afterwards because I wasn't part of this. I was like, you did a CTY? And they're like, well, look what we found. So there's multiple active sites of bleeding, including the chest wall. There's posterior mediastinal hematoma. There's bleeding in both groins. There's multiple rib fractures. There's lung issues, et cetera, et cetera. And I didn't really notice it at first, but they've actually got active bleeding going on from the aorta. So after all of that, he's been through post-arrest, he's been through left main PCI, he's now having aortic bleeding. So they called vascular surgery after going to the IR suite, and I didn't appreciate it at first, but if you look at it, there's a little bit of bleeding going on, extravasating directly from the aorta.
Wow. I gotta say, I've never seen that.
Right.
Fluoroscopy, right? I mean, these are, I don't know. I don't know if it's standard of care.
The French did it in the field.
I know, but if you are in a tertiary hospital where you can have mobile fluoroscopy and everything, this is avoidable. I'm just saying this is not, this is because you're going blind, your wire's going wonky in those little branches, and it's
well, you're assuming it was them, not me. We were both up in the aorta, but I also thought, you know,
no, this is the insertion.
So I'm not sure what to tell you. At our institution, this is sort of standard of care there. They do not have mobile fluoroscopy. Most of the ECMO that comes in or transfers in. Post-arrest, they're done immediately.
Because it's it's surgically owned and managed,
surgically owned, it's not cardiology.
Stefan, I've had cases where chest compression in an anticoagulated patient, they bled from the rib fractures into their chest, into mediastinum, 11 units of blood, and died.
And also watch the way, you know, if you don't have a Lucas and you have someone doing CPR, you know, you get everything from, you know, your best nurse to the medical student, and you know. And you're concentrated, and all of a sudden you're watching the guy pumping over the liver, right? And it's I've had a liver laceration, and she expired from actually intra-abdominal bleeding. So it's very traumatic. It's interesting. We never do those CTs, but I guess these surgeons they know what they expect to find.
But this could be from the chest compression. Like you have.
But this posterior, though, I think the aorta is so deep. I would think it's more traumatic injury at the time of the cannula insertion. But you know, you make a great point, because we've done these bedside ECMOs in radiology just because it's so far away from the cath lab. But there's always an IR suite right there. So should we perhaps not be rushing them to the IR suite and doing it in fluoroscopy? But that's a good point.
Surgeons do it all the time, and like this laceration, I'm not sure it's related to the ECMO. What do you guys think, Tim?
Well, I'm not that familiar with ECMO cannulation. Do these cannulas go in over wires?
They do.
Okay, so
But
you know,
they're
I would
large
assume
bore.
the mechanism here is that they are just out in front of their wire. It looks like it's right at the tip of the cannula, and you know, if you don't have fluoro, you don't really know how much wire you have up. I mean, so that's the feedback to the surgeons, is that they have to be careful.
The cannula is only 17 centimeter.
Pushing wire, you don't know where you're going. You don't have any visualization. I don't know if it's a J wire or if it's a Benson. Surgeons use Benson. It may have gone into a thoracic artery or whatever, and then it bursts the artery.
Yeah.
I mean, they're all full anticoagulation afterward and everything. I just
It's,
don't think it's the right
it's
thing to do.
definitely not the arterial cannula, because it doesn't reach that high. So it is either the wire. It's not J wire. J wire doesn't do that. So it must be something else they use.
Yeah, but it's not like complications don't happen in the cath lab. I will say, as a compliment, you're clearly a very advanced practice. There's videoing and learning from that. I mean, this is really impressive. And I'm sure the ECMO group tracks their outcomes extremely closely. So I think if there was a signal for harm, you guys would be right on top of it. So we're very biased because we're all fluoroscopists. We love it. But I'm not sure I totally buy into that you have to have this done in the cath lab.
And the reason that I show the picture from the overhead is, and I was standing outside the door while they were putting on ECMO, it is an absolute circus in there. They do have the Lucas device. The patient is sick. They're trying to get things done and stabilize them. So it is not like what we see most of the time in the cath lab where things are controlled, et cetera. So we do have this basically hole in the aorta. So the next thing is they'd already got, there's the arrows if you didn't see it. They went from IR and they went to the vascular suite. So here we are with a TVAR. And TVAR took care of the issue, so no more extravasation in either place. There's the TVAR on chest x-ray.
Did he become paraplegic?
No.
Oh, good.
This has a happy ending. So, you know, he went through a lot of things. This is his echo the next day. So post-arrest, left main stent. He was in the hospital for slightly less than a month. He was neurologically intact. He was very grateful. I show you the list of all of the procedures that he had and the diagnoses that came with his stay.
You didn't fix the right. You didn't fix the right CTO.
We're going to leave that for a bit. So just taking a look at complications from ECMO, and as you can imagine, there's pretty much any kind of vascular complication you can imagine. There's tamponade, there's GI hemorrhage, there's cannulation failure, so we have actually seen cannula go outside of the vessel that it was intended to be in. Obviously, they're on a lot of anticoagulation, and you can have bleeds just about anywhere. I was also curious if this has ever been reported before, and interestingly, not exactly. People have done TVAR for patients who came in with trauma, so known trauma to the aorta, been put on ECMO, and then had a TVAR, but I don't know that it's ever been established that the TVAR was placed as a complication from the ECMO placement due to the fact that they had CPR. We actually do a pretty fair job in my hospital with eCPR. We have about 150 to 170 ECMO cases a year, and it's split pretty evenly, VA, VV, and eCPR. eCPR is probably the biggest growing group, and even with the hard stops, there's a fair amount, so we're seeing more and more of these patients come to the cath lab. And even though there's relatively small numbers, our survival is actually pretty good compared to ELSO. So as far as key learnings, ECMO can be life-saving in selected cases with cardiac arrest. Obviously, these are really high-risk patients, and sometimes complications are unavoidable. And as opposed to when we're talking about high-risk PCI and you're saying do we or don't we, there's not a lot of do we or don't we. It's either do it or don't do it, but you don't have a whole lot of decision tree to make. And then again, complications can be from the original event, trauma, CPR, or ECMO placement itself. This patient had, besides these complications, he actually had tension pneumothorax, he had ATN, he had a host of complications related to both his initial insult and the procedures afterwards. And then sometimes treatment of the complications is as important as treatment of the original issue. So if we hadn't put him on ECMO and then we hadn't taken him to the cath lab and then we hadn't scanned him and we hadn't dealt with the perforation, he would not be alive. So happy to entertain questions. It's obviously a very complicated case.
Well, we have a question from Amir Ali.
It seems that your center has a very systematic approach to every single case. How often, this is a one-time case, or you had more of these
No one had ever
aortic?
seen this before.
So I think that argues against bedside. I did my training in the center that a lot of bedside ECMO cannulations happened. I do it fairly enough. I mean, it's great that you have a systematic approach, but it's rather rare, I should say.
Who places ECMO among the audience? Okay. So who places ECMO bedside, not in the cath lab? You did it.
Not routinely. I mean, it's an emergency. You know, it's so hard to bring them around to the CCU. They're big buildings. Everyone has a HVI, heart and vascular, and everyone's on the 8th floor. But what I do is if I'm working with the surgeons, I always get them access and I put the wire before they come in because I don't trust them. Not that they're not good people. I'm just telling you, handing a surgeon amplex wire in an emergency situation requires a lot of courage. And so what I will do is I will put the thing in, and so we cannulate. In our hospital, we have privileges to cannulate, but we don't run the ECMO circuit. So I will get everything ready for them, and then they can go from there.
So after you put an ECMO, would you take him, like, because we put an ECMO bedside, so I did it once, but I routinely don't. But after every time, we take him down to the cath lab, we put the perfusion sheath in. What do you guys do? Rajiv?
Yeah, so I've never cannulated outside of the cath lab, but for perfusion sheath, we'll start with getting SFA access, put a wire in, then do the ECMO, then do the perfusion sheath. But I've had no experience in doing it outside the cath lab. We'll say the ones that come to the cath lab on ECMO from the ED, they've all got massive hematomas in their groin, so it makes the PCI more complicated. That's just another layer of complexity.
Salman?
I think someone made a point that, you know, the leg is perhaps a little bit more tolerant of ischemia. If you're going to the cath lab, then we actually do take them to the cath lab and do the antegrade stick there. So because these patients are not stable, even if they're in VF or recurrent VF and you're shocking them or whatever, the point is that you have time to take them down to the lab and at least do some of the procedure under fluoroscopy, if not all of it. Bedside antegrade sticks almost always have thigh hematomas, almost always.
Stefan?
Yeah, well, I echo what others have said. I think, you know, the big issue is transportation when you are in CPR. There's no way you can walk next to a patient and do CPR and the patient is transported to the cath lab. So you need a Lucas for this. If you have a Lucas, you can run the patient wherever you want in your hospital, get your patient on your table, and get everything ready. And the advantage is these patients will have to go to the cath lab anyway. First. So why don't you put yourself into the best situation where you can actually put your cannulas, be ready to angiogram, and put the perfusion cannula. Doing it on site is only because you're not organized to roll the patient to the cath lab. Perfect. And that's my humble opinion.
So we're gonna move on to the next speaker. Sorry, Amirali. Mauricio Cohen gonna talk about his worst complication. I would like to add, as a prerogative of the moderator, if the CTO was open, he would have coded.
So I don't know if this is my worst complication, but at least it's a complication that I remember. Happened a few years, and there are some few complications throughout your career that end up haunting you a little bit. So this is not a PCI; it's actually a diagnostic.
Mauricio, you have the so you can face. They give you a whole panel there so you can look at it. You can face the audience.
Okay, perfect. Here in the circle. So this is not a PCI, it's a diagnostic procedure. So it's an 82-year-old lady with severe aortic stenosis with just cath, as routinely we do. This happened a couple of years ago. She has multiple risk factors that make her not a good surgical candidate. And so we bring her for the right and left heart cath. So I don't know if you do the right heart cath from the vein, from the brachial vein. So in this case, I was having some difficulties. I ended up getting access I ended up getting access in the brachial artery by mistake, and then I got access in the vein. So I said, well, what the heck, I'll just do it from the arm like I used to do it when I was in training back in Argentina. As you can see, we put two sheaths there in the antecubital fossa. She has significantly tortuous subclavian and innominate. Then the people from Merit was there, and then they gave me a catheter, so it looks like a tiger, but without the little side hole. So we start doing the cath, and any comments about the cannulation? Well, we can keep going. It's a selective cannulation. We're getting good pictures. Then we're taking this picture and this happened. I know it's extracardiac, so wait for the second part. So what do you do now?
This is a guide or a diagnostic?
Diagnostic.
So, and was there a dampening before you injected?
No.
There was no dampening.
No.
I mean, this seems like a kidney to me. It's a kidney guide, and obviously it's a little stiffer. And just the way it's against the wall of the left main, anytime you have, I mean, if you don't, especially if calcification, once you have a rent in the endothelium, the next injection just causes dissection. Unfortunately, you see that with EBUs also if they're undersized.
So, Manoj, so at this stage, what would you do? Put ECMO first, get another access, or just proceed immediately to use a guide and wire? You have a microphone next to you.
Yeah, I mean, I personally being a radial operator, I think that I would go up with a guide and wire and start working as soon as I could, and then maybe work on getting another alternative access for the potential for mechanical circulatory support. But I think my goal is to stabilize the patient as soon as possible. Patient is apparently stable, but before they code is sort of my mindset, and I think I could safely do that from a radial approach.
Can I make a comment? I think the most important observation to me, and I have no idea what happens next, but is that second line, patient remains stable without chest pain. That suggests there is a lumen into that left coronary artery. So your catheter can cause a dissection, lift a big flap, it can look ugly, but right alongside that, there could be a true luminal channel. And if the patient is stable without chest pain, the first thing to do is not to panic. Leave that catheter in, I saw you pulled it out as one option, and bring in a second guide around side, because there has to be a lumen if that patient is stable. So I wouldn't do MCS, I wouldn't do any of that stuff. Personally, you could either, if you're a guide, withdraw and wire, or get a second guide alongside it.
That's excellent. So what would you, what would you do, which guide would you use in this situation? Would you change axis, Dr. Pham? Would you change axis and which guide?
I think saying radial or brachial is appropriate, and I would use a less aggressive guide, so I would not use an EBU. I'd probably stick to a JL35 guide, not a guide that we typically use for left-sided PCIs, but in this case, you want something that isn't going to dive too deep into the left main.
Tim?
I think I probably would not use a JL35 in the sense that that's going to be short, and if it's short, it's going to tend to roof on that aspect of the left main. So I might go femoral because I feel like I can place a guide a little more precisely. I mean, especially given the angulation that you showed, you're sort of at the mercy, you know, you're twirling the catheter and it's oftentimes not doing what you're telling it to do. So, you know, going femoral in this case may allow you to make sure your guide is coming into the left main near the inferior portion where and I agree there's probably a lumen there, so you can sneak a wire through there, and it's, you know, that's much safer.
Salman?
So I love doing radials, but I'm not a radialist. I don't want to make apologies for it. I love doing femoral, and the control you get from femoral is way better than radial. So this is a situation where you want to get femoral if possible. Now, what caused this guide to keep knocking against the left main may have also saved it because the guide is not fully engaged. When you are fully engaged, the dissection just travels down right away. If the patient is without chest pain, you have time to get second access. The main reason to get second access is so that you have the ability to add a circulatory support device if you need to, or maybe use a bigger device. And lastly, what I say is, if the guide is still engaged and you see this, I typically like to try and probe it with a wire. Either you're in the true lumen or the false lumen. If you're in the false lumen, for whatever reason, you have a soft tip wire, the wire curls up, you now know what to avoid. You can then pull the guide back and then try and go alongside it and use dual lumen catheter or whatnot. So I think there are advantages of leaving this guide in place, getting second access, and if the patient's hemodynamically stable, try and probing this with a very soft tip wire and see if you can get across.
Okay, Mauricio, we're going to go back to you.
Yeah, so let's go here. So I followed the advice of some of you. So first, I didn't panic, as Dr. Gulati said. Then, as Dr. Mixon said, I did not use a JL double curve catheter. I used a single curve catheter, which is, an EBU. And I was able to get past the dissection, so inject deep inside, and the patient was rock stable. I was asking, I was looking, I was moving the patient, are you okay? And looking at the blood pressure, she was stable, so that gave me time to assess the magnitude of the problem with IVUS. So IVUS went well. You can see that the vessel, despite the patient being elderly, the IVUS shows at the end of the run, almost outside the left main, that there's a flap. And here, this is actually the flap. And so what do you do next? Patient is stable, you have a flap almost at the ostium, right at the transition with the aorta.
Salman?
No, I was just going to say that. Okay, so you have.
So let's put it. So now I secure the wire. I have a guiding catheter that is probably tucking the dissection towards the roof of the left main. I have full flow into the left coronary system. That dissection is not extending, so we're in a completely stable situation.
So just the way you have STEMI and non-STEMI, you have SCAD and NSCAD. This is NSCAD. So you have a rent in the artery that's not progressing, patient is stable. Just like the SCAD patient who is stabilized. If you have hemodynamic collapse, if you need to stent, sure, stent it. It's a very large vessel. As long as you don't keep injecting, maybe you've fenestrated, maybe you've not. But I would watch the patient in the cath lab for half an hour and try not to stent that.
You would not stent left main rent?
Depending on, it all depends on how far down it went. So if it stays within the body of the left main, I wouldn't stent it. If it's extending to one of the major branches, then I would.
I'm going to ask the audience, who would stent it?
100% of the time. When God is kind to you, you don't test him more.
Who would not stent it? Oh, you would not stent it? I thought you raised your hand.
What about Dr. Phil? Dr. Phil there, he was my fellow many years ago.
Okay, so...
You'd stent it?
Okay, you stent it. Stefan, why would you stent it? Why would not stent it?
I think the dissection is not in the left main. It's just on the edge of the left main. You see that very, very small tear at the aorta right there. Mm-hmm. There's a very large lumen. And the way it was puffing up, it was outside the left main. It's not in the left main, the dissection. It's in the aorta. It's like a sinus dissection here.
And how would you guarantee that it's not going to extend with the pressure and pulsatility?
But I think I would do exactly what Salman said. I would observe this patient, try to see, maybe wait a bit, and it can well be the same physiology as a SCAD. But again, I think nobody does wrong by stenting, right? It's a big vessel. It's easier to say than do, not to stent.
The patient is going to have a TAVR probably in a week or in a couple of weeks, and then you're going to have a stent sticking out. So you have to think twice.
You're right. Go ahead, Mauricio. What did you do? That's
okay. So we didn't stent him.
You did not?
I did not stent the patient. The patient was rock stable. That the flap was not progressing. I had a wonderful lumen there. I was reassured by the IVUS that it was a small segment of the left main at the ostium of left main. So the patient was fully anticoagulated. And remember, these are non-cardiac complications of this procedure. So we sent the patient upstairs to the unit under very close observation. As Salman said, I listened to him. I watched the patient in the cath lab. So the sheath was removed. The tech, which was one of our best techs, told me that the sheath came out without any issues. And then the patient stayed overnight. The following morning, a call from the CCU attending horrorized that the arm looked like a blood sausage. She's in excruciating pain with tingling in the fingers. Ultrasound shows a pseudoaneurysm with hematoma, cannot compress because the patient is in extreme pain. So we asked our vascular surgeons to give us a hand, and they did. So they evacuated the brachial hematoma, Unfortunately, the patient suffered because there's a nerve going along with the vein and the brachial artery. So that's how the patient's arm looked. It was, to me, it was horrendous. I'm used to doing radial, minimalistic approach procedures. Nobody would like to see that. And then the patient was seen by a neurologist. The patient had a median nerve injury, could not oppose a finger with the index, the thumb with the index finger. There was anterosseous nerve dysfunction. So, so what I'm learning here, and what I learned the hard way in a couple of ways, that brachial access is never good. If you can avoid brachial access, just avoid. There's no good compression plane. It's terminal circulation. If you have a complication there, you put the whole forearm at risk. So radial is great. You have always collateral circulation, small vessel, and then the radius acts as an ambule for compression. So, but avoid at all costs to go brachial. So what's happened with the dissection? The patient came back for TAVR. So a month later, we did an angiogram. And that's the angiogram, the follow-up angiogram. The dissection had already healed. So
you didn't use the same catheter.
I did not use the same catheter. So had I used the Tiger, so there was a seam, it was like a Tiger looked like. That's my regular practice Tiger catheter. But the Tiger has a little side hole before the tip. And that, I think, decompresses. This catheter was very rigid without the side hole. And that's why the force of the injection went towards a relatively healthy left main that was vulnerable to dissection.
So let's say someone end up with a brachial access like this. Would you use a closure device? Anybody will use a closure device? Because there is no way, there is no good way to hold the brachial artery.
And then we're not used to holding anymore, right? When I was in training in Argentina, we're using lots of brachials before radial.
But you did a cut down or a sheath?
No, sheath. Percutaneous.
So you held it?
But we used to hold. We used to hold groins, 8 French groins, and we knew how to hold. We learned.
But nobody.
Now, if you ask a fellow, go hold an artery, they don't know how to do it.
Yeah.
Okay.
And the techs don't know how to do it. So I think it's something that's been lost.
Hate brachial access, but our interventional radiologists, if it's a 5 millimeter brachial, they'll perclose it.
You'll perclose it, Salman?
So no, we don't close. It's the worst access. I would stick the carotid before I stick the brachial. That's not true. That's not true. I just said that for controversy. But we do is, so the last time I did a brachial was actually a very tall person who needed SFA work done. We were doing R2P. The sheath just wouldn't reach for the stent system. And typically, if I have to do brachial, obviously use ultrasound, use all the techniques we talked about, do a sheath shot. But then on the way out, I will actually, if I'm doing manual pressure, do the radial to do a injection just to make sure. In the past, I've done pretty much everything, perclose, minx, angioseal. The problem is you don't have big tract to work on. A lot of these devices require a tract. So unless upfront you're going in to do a closure, you go very, very shallow so you have a tract to work with, everything sticks out of the skin. So if I have to do it, I would just do manual compression. If need be, you can use the radial for internal balloon tamponade as long as you don't overstretch it, but almost always take a picture after you do the brachial access if you can to make sure it's still not bleeding.
Manoj?
I was wondering if you could elaborate more on what type of anatomy for which you do a perclose. In a sec here, I just had another comment that I feel like for ulnar arteries and brachial arteries that may be deep, that manual pressure may be the best approach. I find, particularly for the ulnar artery, that when it's deep, the transradial compression band just doesn't get deep enough to hold the pressure, keep the hemostasis.
So no, it is. And so I think the nuanced statement there is experience. The brachial is very difficult because naturally it's a very tortuous artery because it has to accommodate the flexion of the arm and whatnot, especially if you're hypertensive. And the problem is you're compressing on a very round bone. There is no place you can compress it. Even the popliteal is better than this because you have the knee joint to compress it against. The problem is it can roll from under your skin very easily, under your fingertips very easily, and you just won't know because the arm just keeps accumulating all that blood. It's a very tricky artery to hold manual pressure on.
Okay, go ahead.
Sorry, just one comment. We do very rarely brachial access, but one other idea was to hold the manual compression with the ultrasound probe. So then you are sure that you are compressing at the correct site and it's not rolling over, so you have immediate feedback if your compression is not appropriate.
Thank you, Mauricio. That's amazing. Thanks a lot. Well, actually, I marked the time on my talk, so I'm going to go give my talk now.
All right, so again, I think the message is avoid brachial. Having said that, I must admit, we did have a brachial case last week. There was no other access. And the key there, I think, is to have someone hold manual pressure after the ACT is normal. So never pull this one unless the ACT is within the normal range.
Okay, the best talk of the day, the last talk of the day. Okay, radiation protection, yes, I can. I didn't know why, yes, I can, because we all can, not only I. So the radiation protection, we're going to talk about the biological risk, how to monitor the risk, ALARA, and some kind of tidbits about how to do radiation. And CTO operators they had to be very facile in radiation management throughout the procedure, because that was one of our failure modes. Like you get out of radiation, you get out of gray, and you cannot actually proceed anymore. So very good publication by a friend of mine, Srini Patluri. I advise everybody to read it. In the Sky, it's about 2 minutes reading, so it's really great. Radiation, biological effect, stochastic and deterministic, as if everything in radiation written by Greek. So, so that deterministic effect is dose dependent and a threshold. There is a threshold. That's what the radiation dose. Think skin injury. Like you have to reach 2 grays on one spot to get to the skin injury. There is a threshold and there is a dose dependent. The stochastic, it's a different. There is no threshold. Think cancer. Any exposure could actually end up damaging the cells, causing mutations, whatever. So this is how the difference between the stochastic and deterministic. So there are certain things you really have to know to protect yourself and you protect your cath lab staff, and more importantly, to protect your patient. You have to know basic information and you have to monitor this information. Fluoroscopic time really doesn't mean anything. It just means that your procedure is long. With that, previously, that was the only thing, when I was a fellow, the only thing we monitored. And it turned out I have more fluoroscopic time, but because my physicist is excellent, I actually get less radiation because the device is optimized. So what you have to watch the amount of radiation you bring into the patient. The air karma, this is what you watch. And it should be available. Do you see that AK on the screen? That's the air karma. You watch that. That's what you watch when you are actually doing the procedure, and you set limits. So in CTO world, 5,000, you have not achieved a lot of progress, you stop. If you're about to put a stent, we allow ourselves to 8,000. But if you get to 5,000, you've done very long procedure and you should probably stage it. So the air karma is measured by gray or joule per kilogram. The amount of energy at the reference behind the patient, 15 centimeter from the center of the patient behind him. This is what goes into the air. This dose area product, I monitor it, but I don't understand it much. My physicist understands it and calculates it every time I exceed certain dose. They go calculate how much radiation the patient got. And that dose area product, Tusawi, I used an Arabic word there, Tusawi. That's a word for equal. Peak skin dose, you can monitor that. This is important because if you concentrate on only one angulation, you're going to deliver a lot of dose to one area of the skin, and then you're going to have an injury. So that's going to come later. Remember, the buck stops with you as an operator. You are responsible for everybody's safety, including yourself in the cath lab. Sorry about that. So this concept, all of you should be familiar with it. You know, as low as reasonably achievable. That goes for everything we do in medicine. So there are, first, no safe dose of radiation. So you have to assume any dose is not safe. Radiation can pile up, so it's the cumulative, and smaller doses equals less risk. So prevent radiation-induced skin injuries. This is from Chambers and his colleagues since 2011. This is still actually valid. I'm gonna go over this. Limit fluoroscopy. Do not be on the pedal while your eyes not on the screen. This is the first thing I teach the fellows. Cine is a lot more radiation than fluoroscopy. Actually, 1 second of fluoroscopy equals equals 1 frame of cine equals 1 second of fluoroscopy. And remember, there are 15 frames per second per cine. So you are actually given a lot of radiation when you do cine. So the cine should be limited. Limit magnification. If you magnify, you're increasing the dose. You can actually monitor that in your lab. When you go from 25 centimeter field to 820, you'll see that the air karma projections actually increase. Collimation is good. Do not stay in one angle, because that's when you cause injury, especially when you bring the patient for a staged procedure. Don't go to the exact. Even 5 degrees off, that will be helpful. Position the table. We'll talk about that later. Keep body parts and clips, whatever, out of the field, because that actually increases the energy, and reduce frame count. That's actually one of the tricks we had to learn early when we start doing CTO PCI. And monitor the dose, and sometimes inject. There are a few steps. So on the right side, you look at the angulation, REO, LAO, cranial, and caudal. The more angulation, the more radiation. That green zone is the best. It's between like 20 to 40 on each side. These are actually the least of radiation, because when you angulate, you increase the amount of tissue the beam has to go through, and the machine will automatically adjust and increase the KEV to basically penetrate that tissue, so it can give you a better picture. So every time you angulate, you have to remember that. Nothing bugs me than seeing something like the balloon pump, the EKG in the middle of the field. If you are taking your wedding picture, would you leave green vegetables between your teeth? If I see a picture I get a lot of films, when I see a film with actually clips sitting on the chest and the angiographer doing pictures, I think I would not trust this person with my family. That's a sloppy work. You increase your dose, your patient dose, and your staff dose when you leave metals in your field. It's easy to remove. Pacemaker you cannot control. I try to keep the pacemaker out of the field so I can get a better picture. So do not leave objects in your field, because that tells everybody that you are not really doing a good job. So how to use the cath lab X-ray device. These are technical things, and you have to keep that in your mind. There are a lot of devices, old devices, that will burn the heck out of you and your patient and your staff. And these devices should be not used, and you should bug your CEO, the CMO, and your physicist to replace them. There are a lot of measures you can do, and sometimes you have to lobby the higher-ups to kind of buy you a new device. If you have the patient should be as far as possible from the source, and the II or the image intensifier as close to the patient. And if you notice here, the dose of radiation increases distance from the image intensifier. So, and that actually also increases the scatter that hits you and hits your staff. How about yourself and staff? We're talking about the patient. These devices now are commonplace and they are working. They're going to be actually optimized. You should obtain them for your cath lab. They decrease the dose for everybody, including your staff, and that should be the way of the future. So method to reduce radiation exposure, novel, remove operator, robotics, unique, and training and awareness, by the way, it works, but is not as good, and I'm going to show you why. This device like real-time monitoring, has been shown to modify behavior of the operators and change the radiation dose they receive. So this is me and one of my ex-CHIP fellow, Saroj Nupani. If you notice, the shield is sitting in a different spot than me, so you shouldn't do that, what I'm doing here. You should always keep the shield between you and the operator and the patient. So how about the idiot-proof method? So we are actually dependent on training and behaviors and everything. How about the machine? There are actually algorithms now, the Alora algorithm, the CSO algorithm, they're published in JACC, that showed is actually more effective than a whole lot of training and posters and reminders in decreasing the patient's, your dose, and everybody's dose. And I call this the idiot-proof method to prevent radiation exposure or decrease your dose. So you should ask for these algorithms for a new technology. If you're using a 14 years old cath lab, you should probably quit using it. And one of the problem, I try to make things idiot-proof, but they keep making better idiots. So you might not win with that. Thank you so much for listening to me. Any questions?
Cal, I have a question. Yeah. So what radiation protection system do you guys use, the lead-free system, and what are your experiences with that?
I use the Rampart, and the Rampart adds about 5 minutes to the setup of a patient. You cannot use a Rampart. You cannot use any of those devices where you are actually without your lead without having a real-time dosimeter. Yes, Mauricio.
So I have a question for you, and this is the other battle we have. So how much is Rampart, and how willing the administrators are to install one of those devices in your lab?
They're not willing. They are 170K, I think, 170,000. I don't know what's the average price of the Rampart, but they are very, very expensive devices, which you make this amount of money by doing 4 STEMIs for the hospital. So I think they should buy you that. Any other questions? All right. So any final word from the panelists?
Well, I just want to tell you my Rampart experience. So we're in the process of acquiring it. And one of the issues is that our radiation office safety officer wouldn't send the letter to the state until we tried it out with our lead on. So I found it a little cumbersome because I had lead on, then I had Rampart. I couldn't do my peripheral cases that well. So you can't use for every case. But what was interesting is apparently sometime later this year they're coming from with a system that hangs from the ceiling, and I'm wondering if you know anything about that, and should we just then, rather than purchase one in the next 4 weeks, wait until the fall or something like that?
You should wait. By the way, we had to apply for the state licensing board in Michigan and the nuclear agency, whatever, and like radiation agency in Michigan. They had to apply to allow me to be without a lead. It turned out like it's not legal to be without a lead. So you should talk to your physicist in the department. Manoj, do you have any final thoughts?
No, I was just kind of following up on the discussion here that I feel like if you're going to use a Rampart system, real-time monitoring really needs to be a part of it. I was just going to mention, I feel as though real-time monitoring also is very educational to the operator themselves. So I think as much as we can do that, the better.
And that's the best advice. We're going to leave you with it. Thank you so much.
So one thing before we depart, there are 2 symposia for this evening. Since you didn't get enough information, you have opportunities to hear more. There is the Heart Team Symposium and also the Innovation Summit. Actually, this is the Innovation Summit. It's about financial information and retention and everything else. So completely different from the tips and tricks, but might be important. And then tomorrow morning, 2 breakfast symposia as well, one for TCB and one peripheral as well. So thank you again so much. Great discussion, and see you at the symposium.